Welcome to the deep dive. Today we're tackling a really complex condition, complex regional pain syndrome, CRPS.
That's right. It's a tough one.
We're using Rutherford's Vascular Surgery and Endovascular Therapy, 10th edition, as our main source, a chapter specifically on CRPS.
Yep. A solid medical perspective.
And our goal here is to really unpack this for you. What is it? What might cause it? How it's diagnosed? And importantly, what treatments are out there?
Exactly. We want to give you, the listener, a clearer picture than maybe you've had before, hitting the key points without getting totally lost in the weeds.
Okay, let's get right to it then. What exactly is CRPS? Can you break that down?
Sure. So fundamentally, CRPS is a chronic pain condition, usually pops up in an arm or a leg.
Okay.
And it seems to involve, well, an over-the-top response from the body.
Yeah.
You get inflammation, yes, but also changes in the involuntary nervous system.
The autonomic system, like breathing, heart rate, that stuff.
Exactly that. The system controlling things like blood flow, sweating, things you don't consciously manage. And the pain, well, the pain is the main event.
Right.
It can just start spontaneously, or maybe something triggers it. But the hallmark really is that the pain level is way, way beyond what you'd expect from whatever started it, if anything did.
Disproportionate pain. That phrase really sticks out. And it's not just pain, is it?
No, definitely not. I mean, the pain itself can be intense, often described as burning or maybe extreme sensitivity. Even a light touch can be agony. That's allodynia.
Wow.
But alongside that, you often see physical changes in the limb. Skin might change color, feel hotter or colder than the other side. You might get swelling. And frequently, there are motor issues like weakness or stiffness and sensory disturbances beyond just pain, all of which can really impact a person's ability to function, cause significant disability.
It's interesting how the name itself has evolved. Causalgia, RSD.
Oh, absolutely. Those older names, Causalgia, Reflex Sympathetic Dystrophy, or RSD, neural oligodystrophy, they kind of reflect the journey of understanding or trying to understand what's going on. The current term, complex regional pain syndrome, was only formally adopted in 1994 by the IASP, the International Association for the Study of Pain.
1994 feels relatively recent for defining something so impactful.
It does. And what's really telling is that even now, with decades more research, actually diagnosing it and finding consistently effective treatments, still a major challenge.
Okay, so if it's challenging and there's no single CRPS test, how do doctors figure it out? What do they look for?
Right, good question. It's primarily a clinical diagnosis, meaning it's based on what the doctor sees and hears from the patient, usually over multiple visits.
Multiple visits, okay.
And it's a diagnosis of exclusion. That's key.
Yeah.
They have to rule out other things first that could potentially cause similar symptoms.
So tests are used, but more to rule things out.
Exactly. Things like X-rays, MRIs, maybe nerve conduction studies.
Yeah.
They help eliminate other possibilities, but they don't confirm CRPS directly.
And the specific criteria they use, those have changed too, right? You mentioned Veltman criteria earlier.
Yeah, exactly. Earlier criteria, like the Veltman ones, focused on pain, skin changes, swelling, mobility issues, but they weren't always specific enough.
Really?
Meaning they sometimes pointed towards CRPS when actually something else was the root cause, led to some misdiagnosis potentially.
Yeah.
Then in 94, the IASP criteria came along. Better sensitivity. They were good at catching most actual cases of CRPS, but still maybe not specific enough. They could still sometimes flag people who didn't truly have it.
So what's the current gold standard?
Nowadays, it's the Budapest criteria. They were developed to improve that specificity, being more certain it is CRPS, by requiring observable clinical signs found by the doctor, not just relying on patient reports.
Okay.
But they aim to do that while still keeping the sensitivity high so you don't miss cases. It was about refining the diagnosis, making it more accurate.
Budapest criteria. Okay, walk us through those. What are the key things a doctor is looking for?
Okay, so the Budapest criteria break it down. First, you need that history of ongoing pain that seems disproportionate to any inciting event.
Right, the disproportionate pain again.
Then, the patient has to report at least one symptom in 3 of these 4 categories. Sensory, think hypersensitivity, like allodynia or hyperalgesia.
Okay.
Vasomotor, that's changes in skin color or temperature differences between limbs. Pseudomotor, issues with swelling or changes in sweating patterns.
Got it.
And mototrophic, this includes things like decreased range of motion, weakness, tremors, or even changes in hair or nail growth on the affected limb.
So that's what the patient reports. 3 out of 4 categories. What else?
Then, crucially, the doctor has to observe at least one clinical sign during the examination in at least 2 of those same 4 categories.
Ah, Okay, so the doctor needs to see or feel something too.
Precisely. They might find evidence of allodynia to touch, or actually see the skin color or temperature difference, or observe swelling, or notice weakness or limited movement firsthand.
That makes sense. Adds an objective layer.
Exactly. And then finally, they confirm no other diagnosis explains the symptoms better. And CRPS is subdivided. Type I is when there's no major nerve injury identified. That's the old RSD. Type 2 does follow a distinct nerve injury like the old Causalgia.
Type I and type 2. Okay, so this paints a much clearer picture of the diagnostic puzzle. Who tends to get CRPS? Is it common? Rare?
Well, the numbers? They vary quite a bit depending on the study you look at.
Why the variation?
Part of it is probably those changing diagnostic criteria we just talked about. Different studies might have used different rules. Plus, the population studied can differ.
Makes sense. But any ballpark figures?
Sure. One U.S. study suggested maybe 5 or 6 new cases of type I per 100,000 people per year, and less than 1 for type 2. But then a study in the Netherlands found a combined rate closer to 26 per 100,000.
Wow, that's a big difference, 5 versus 26.
It is. Could be population differences, could be how strictly the criteria were applied. It's hard to say for sure.
But any common threads? Who's more likely to be affected?
Generally, studies agree it's about 3 to 4 times more common in females.
Oh, interesting.
And it tends to affect the upper extremities, arms and hands, more often than the legs. Peak age for diagnosis seems to be between 50 and 70 years old.
Are there known risk factors? Things that might predispose someone?
Yeah, a few have emerged. Things like menopause, having osteoporosis, and smoking seem to be associated with a higher risk.
And injuries. I imagine injury is a big trigger.
Oh, definitely. Fractures are a major one. The reported incidence after something like a radius fracture in the forearm varies wildly in studies, from maybe 1% up to 37%.
37%. That's huge.
It is surprisingly high in some reports. For ankle fractures, maybe around 15%. Wrist fractures, around 8%. One study looking at tibial fractures found CRPS in 30% of patients.
So breaking a bone seems like a significant risk. What about surgery?
Yep, surgery too. It's been reported after all sorts of procedures, carpal tunnel release, fixing Dupuytren's contracture, distal radius surgery, shoulder surgery. The rates again vary, maybe 1% up to 40% in some series.
40% after some surgeries? That's concerning.
It is. Also seen after things like external fixation for fractures, open fracture repair, foot and ankle surgery. Basically, any significant trauma or surgical intervention on a limb carries some risk, it seems, in people who are susceptible.
Okay, so let's dive into why. What's the thinking on the underlying mechanisms, the pathophysiology? This sounds like the really complicated part.
It absolutely is. And honestly, we don't have all the answers, but the current thinking is that it's this really complex interplay between multiple systems.
Like?
Neurological factors involving nerves in the limb, the spinal cord, the brain, and that autonomic system we mentioned. Inflammatory factors, the immune system getting involved, and maybe even immunological factors like autoimmune processes.
Wow.
Plus, psychological factors can influence it, and there might even be a genetic component for some people.
So it's not just one thing.
Definitely not. And the specific mix of these factors probably varies from person to person, which likely explains why CRPS looks so different in different individuals.
Let's unpack those a bit. Start with inflammation and the immune system.
Okay, so those early signs, the pain, the swelling, redness, warmth, they strongly suggest an exaggerated inflammatory reaction, right?
Makes sense.
And indeed, studies find increased levels of inflammatory mediators, things like bradykinin, substance P, CGRP, and also inflammatory signaling molecules called cytokines, like TNF-alpha and various interleukins, in affected tissues or fluids.
So the body's chemical alarm signals are ramped up.
Exactly. There's also evidence linking it to oxidative stress and maybe even ischemia-reperfusion injury, like when blood flow is cut off and then restored. Animal models show this can trigger CRPS-like features.
Okay, and you mentioned an autoimmune angle.
Yeah, this is really interesting. Some research has found autoantibodies mistakenly targeting the body's own tissues directed against receptors in the autonomic nervous system in some CRPS patients.
So the immune system might be attacking parts of the nervous system.
It's a possibility being actively explored. It suggests that, for at least a subset of patients, CRPS might have an autoimmune component driving some of the symptoms.
Fascinating. What about the nerves themselves, in the skin of the affected limb?
That's another area of focus altered cutaneous innervation. Some studies using skin biopsies have found a lower density of small nerve fibers, particularly the ones that sense pain, in the affected limb compared to the unaffected one.
Fewer pain nerves. Wouldn't that mean less pain?
You'd think so, but it's more complex. There might be fewer normal fibers, but maybe an increase in abnormal or regenerating fibers, suggesting nerve injury and potentially altered signaling. Some types of fibers might decrease while others change structure.
So the wiring is just messed up?
Kind of, yeah.
Oh.
But these findings aren't universal across all CRPS patients, so their exact role is still debated. It's likely one piece of a larger puzzle.
Okay. And you mentioned sensitization earlier. Central and peripheral. Can you explain that more?
Sure. Sensitization is a key concept in chronic pain, including CRPS. It basically means the nervous system becomes hyperexcitable, overreacting to stimuli.
Okay.
Peripheral sensitization happens out in the limb, at the nerve endings. Inflammatory mediators released after the initial injury can make these nerve endings more sensitive, lowering their threshold for firing. So they send more pain signals for less reason.
Right.
Then there's central sensitization. This happens in the spinal cord and brain. Persistent pain signals coming from the periphery can cause changes within the central nervous system itself.
How does that work?
Key players are neurons in the spinal cord becoming more responsive. This involves neurotransmitters like glutamate-activating specific receptors, especially NMDA receptors. Think of these as amplifiers for pain signals. In CRPS, these amplifiers get turned up way too high.
So the volume knob for pain is stuck on high in the spinal cord?
That's a good analogy.
Yeah.
And this leads to those hallmark symptoms of neuropathic pain. Hyperalgesia, feeling excessive pain from something actually painful. And allodynia, feeling pain from something that shouldn't hurt at all, like clothing brushing against the skin.
Okay, that makes the disproportionate pain make more sense.
Exactly. And some research even suggests long-term structural changes might occur in the brain, particularly in the somatosensory cortex, which processes touch and pain, possibly contributing to motor problems or that feeling of the limb being foreign.
Yeah, okay. And the autonomic nervous system, the sympathetic system, how does that fit in again?
Right. Autonomic dysfunction is crucial. We see impaired regulation of the sympathetic nervous system, the fight or flight system.
Yeah.
And critically, there seems to be an abnormal coupling or connection between sympathetic nerve fibers and pain-sensing nerve fibers.
Meaning
That activity in the sympathetic system, like releasing adrenaline or noradrenaline, can actually trigger or worsen pain in the affected limb. Normally, these systems don't interact that way.
How does that happen?
Animal studies suggest that after nerve injury, adrenergic receptors, the receptors that respond to adrenaline, can actually start being expressed on pain fibers themselves.
So pain nerves start listening in on stress signals.
Essentially, yes. In early CRPS, you might see increased circulating adrenaline, leading perhaps to vasodilation, widening of blood vessels, causing warmth, redness, swelling.
Okay.
But over time, the system might become hypersensitive to sympathetic signals, leading to vasoconstriction, narrowing of blood vessels. That could explain why, in chronic CRPS, the limb often becomes cold, sweaty, and maybe bluish.
So the autonomic picture can change over time, very complex. What about psychological factors? Depression, anxiety?
Well, people with CRPS certainly can experience anxiety and depression, but the prevalence seems pretty similar to other chronic pain conditions. It's not clear if they cause CRPS.
But do they affect it?
It seems they might. Some evidence suggests depression and anxiety might worsen the experience of pain in CRPS more than in other conditions.
Why might that be?
One theory relates back to that sympathetic pain nerve coupling. Stress, anxiety, depression. These states can increase catecholamines, like adrenaline. If those stress hormones then directly trigger pain via those aberrant connections, you can see how psychological state could directly impact pain levels.
I see, like a vicious cycle.
Potentially, yes. And there's also some thought that psychological distress around the time of the initial injury might increase the risk of developing CRPS or influence its severity. One study linked depressive symptoms around knee surgery to worse CRPS outcomes later.
That really highlights the mind-body connection.
Absolutely. It's all interconnected.
Lastly, you mentioned genetics. Is CRPS hereditary?
There are hints, but it's not clear-cut. We see some families where it seems to run maybe with multiple limbs affected or earlier onset.
But no specific CRPS gene?
Not yet. No clear inheritance pattern identified. But there is growing research linking CRPS to certain immune system genes, specific HLA genotypes. And one gene called MMP9 has been found to be upregulated.
So maybe a genetic predisposition makes someone more susceptible if they have an injury.
That's the idea. But much more research is needed to confirm any definite genetic links. It's likely a combination of genetic susceptibility and environmental triggers, like injury or surgery.
Okay, that gives us a good sense of the complex web of factors involved. Now, practically speaking, when someone comes in with these symptoms, how do doctors evaluate them beyond the Budapest criteria? Any tests that are particularly helpful?
Well, as we said, diagnosis is mainly clinical, but tests play that crucial role of supporting the diagnosis and, importantly, ruling out other things.
Right. So what kind of tests might they use? Imaging.
Yeah, imaging can sometimes offer clues, though nothing is definitive for CRPS itself. Plain X-rays, especially later on, might show bone changes like thinning osteopenia or patchy demineralization near joints.
But that's not specific.
No, not specific. A triple-phase bone scan can sometimes be suggestive. It might show increased blood flow and tracer uptake in the affected limb, particularly in the early phases.
Okay, what about MRI?
MRI can show things like skin thickening, soft tissue swelling, maybe muscle atrophy, or patchy bone marrow edema. Again, not specific to CRPS, but useful for seeing the extent of tissue changes and ruling out other problems like infections or tumors.
So imaging helps paint the picture and exclude other causes. What about nerve blocks for diagnosis?
Yes, diagnostic sympathetic blocks can be quite telling.
How does that work?
An anesthetic is injected near the sympathetic ganglia that serve the affected limb, the stellate ganglion for the arm, or the lumbar chain for the leg.
And what are they looking for?
Significant pain relief following the block strongly supports CRPS. If the pain doesn't change much, it makes CRPS less likely it has a high negative predictive value, meaning lack of relief is a strong indicator it's not sympathetically maintained pain.
Does it always mean CRPS if the pain gets better?
Not necessarily. Other conditions like ischemic pain can also improve, but the degree of relief is often much more substantial and sometimes longer lasting in CRPS compared to just temporary numbness. So it's a strong clue when positive.
Okay, that makes sense. Now, thinking about the journey with CRPS, what's the typical natural history? Does it get better on its own?
It's really unpredictable, unfortunately. Symptoms usually start within, say, 3 to 4 months of a trigger. A diagnosis made much later than that is less common.
And the outcome?
Varies hugely. Acute CRPS, defined as less than a year, seems to have a better chance of spontaneous resolution, sometimes even with limited treatment. Some studies suggest maybe up to 74% resolve.
That's hopeful for early cases.
It is. But chronic CRPS lasting over a year, that's a different story. Spontaneous resolution is much less common. One long-term study found only about 30% resolved, while over half stayed the same or even got worse over 6 years.
So chronicity really changes the outlook.
It seems to, which really emphasizes why catching it and starting treatment early is thought to be so important.
Right. So let's talk about management. What are the main strategies? You mentioned multidisciplinary care.
Yes, because untreated CRPS can lead to such profound chronic pain and disability. A comprehensive approach is key. While, honestly, high-quality evidence for many specific treatments is lacking, the consensus is that combining different therapies is usually best.
What does that typically involve?
Usually a cornerstone is physical and psychological therapy, then pharmacological management medications, and often interventional procedures like those nerve blocks we discussed, or even more advanced things.
Okay, start with physical and psychological therapy. What's the goal there?
The main goals are to improve function, maintain or regain mobility, and reduce pain, obviously. A big problem is fear avoidance. People stop using the limb because it hurts, which leads to stiffness, weakness, and more pain. It's a cycle.
So therapy tries to break that cycle.
Exactly. Physical therapy uses gradual exercises, range of motion, strengthening, maybe hydrotherapy, massage. Occupational therapy focuses on integrating the limb back into daily activities. Things like elevation, splinting, managing swelling, stress loading exercises are also used.
Stress loading? What's that?
It involves gradually increasing weight bearing or pressure through the limb, like scrubbing the floor or carrying objects, to kind of re-normalize sensory input. Ideally, this happens in a specialized pain clinic setting.
And the psychological side.
That's crucial for addressing things like the distorted body image that can develop, kinesiophobia, the fear of movement and coping strategies, and techniques like mirror therapy and graded motor imagery can be really powerful here.
Ah, yes, you mentioned those. Tell us more about how mirror therapy works again.
Right. You place a mirror vertically between the limbs, hiding the affected one. The patient looks at the reflection of their unaffected limb moving, while trying to move the affected limb similarly behind the mirror.
So it tricks the brain.
Essentially, yes.
Yeah.
The brain sees the visual feedback of normal, painless movement, and this can sometimes override the abnormal pain signals and help remap the brain's representation of that limb. Studies show it can improve pain and function in CRPS type I.
Fascinating. And graded motor imagery.
GMI is a more structured, three-stage process. First is laterality recognition, just identifying pictures of left versus right hands feet quickly. Second is imagined movements, mentally rehearsing, moving the affected limb without actually doing it. Third is using mirror therapy.
Kind of exercising the brain's motor pathways without triggering the pain.
Exactly. It aims to re-engage those cortical motor networks gradually and safely. GMI has also shown benefits for pain and function. Both are really patient-centered approaches.
Okay, so PTOT and these specialized psychological therapies are foundational. What about medications? It sounded like a lot of options earlier.
Yes, there are many classes used, often targeting different potential mechanisms. Anti-inflammatories like NSAIDs or corticosteroids are sometimes tried, especially early on.
Do they help?
Evidence for NSAIDs is pretty weak in CRPS. Corticosteroids like prednisolone seem more promising in some trials, particularly for acute CRPS, maybe reducing that initial exaggerated inflammation. Less clear benefit in chronic stages or for long courses.
Okay. What else?
NMDA receptor antagonists, things like ketamine, aim to target that central sensitization we talked about. Results are mixed, and toxicity can be an issue with ketamine.
Right.
Then you have the standard neuropathic pain medications. Gabapentin is widely used and has shown effectiveness in reducing pain and sensory issues in CRPS. Tricyclic antidepressants like amitriptyline are also common. Some anticonvulsants like carbamazepine have shown some benefit too.
So drugs targeting nerve pain directly.
Correct. Opioids. Well, they're sometimes used, but there's little specific evidence they're particularly effective for CRPS pain. And they come with all the usual risks of tolerance and side effects, usually used cautiously, if at all, as part of a bigger plan.
Okay. Any others?
Drugs targeting the sympathetic system, antihypertensives like clonidine, sometimes used topically, or alpha blockers like phenoxybenzamine have been tried, again with mixed results. And medications for bone health like calcitonin or bisphosphonates, example alendronate, might be used if there are significant bone changes, as they can sometimes help with pain and swelling too.
Wow, quite an arsenal, but sounds like a lot of trial and error.
It often is, unfortunately. Finding the right drug or combination for an individual can take time.
What about those nerve blocks, again, the sympathetic blocks? Are they just diagnostic or also therapeutic?
They're used for both. After diagnosis, a series of blocks might be done therapeutically to try and provide longer periods of pain relief and facilitate physical therapy.
How successful are they?
Non-randomized studies often report pretty good initial relief, maybe in up to 85% of patients. But sustained long-term relief seems less common, maybe 60% or less. And importantly, randomized controlled trials comparing blocks to placebo haven't consistently shown a significant benefit for pain outcomes. A Cochrane review couldn't really support or refute their use based on the evidence.
So the evidence is weak, but they're still commonly done.
Yes, they are quite common, especially early on if conservative measures fail. Usually a series of 3 to 6 blocks is tried. If a patient gets consistent, significant temporary relief from the blocks, then a more permanent procedure like sympathectomy might be considered.
Right, sympathectomy, interrupting the sympathetic nerves more permanently. How's that done?
Several ways. Chemical sympathectomy involves injecting alcohol or phenol near the sympathetic chain to destroy the nerves. Radiofrequency ablation uses heat for more precise destruction. Or surgical sympathectomy, removing a section of the chain either open or endoscopically.
Which is preferred?
Chemical is less precise, can be painful, and might complicate later surgery. Radiofrequency is more precise than chemical, but may be less complete or durable than surgery. Surgery, especially endoscopic now, allows direct removal of the targeted ganglia, usually T2, T4 for the arm, L2, L4 for the leg.
Are there risks with sympathectomy?
Oh, yes. Besides the usual surgical risks, a big one is post-sympathectomy neuralgia. New, often burning pain, typically in the thigh after lumbar sympathectomy. Compensatory sweating in other areas is common. Horner's syndrome is a risk with upper limb procedures if the stellate ganglion is involved too much, and other potential nerve injuries or bleeding. It's definitely not a minor undertaking.
Okay. What other interventional options exist if blocks and meds aren't enough?
Neurostimulation is a major one. Spinal cord stimulation, SCS, is the most established.
How does SCS work?
Electrodes are placed in the epidural space near the spinal cord, connected to a battery pack implanted under the skin. It delivers electrical pulses thought to interfere with pain signals traveling up the spinal cord, maybe also calm down sympathetic activity and improve blood flow.
Does it work for CRPS?
Results are variable. Some studies show benefit, others less so, especially long-term. One trial showed improvement over physical therapy alone at 2 years, but not at 5 years, and complications like infection or lead migration occurred in over 40%. Overall, maybe 40–50% of patients get meaningful relief.
Okay. And you mentioned DRG stimulation earlier, dorsal root ganglion.
Yes, that's a newer, more targeted approach. The DRG is where the cell bodies of sensory neurons sit. Since pathological changes might happen there in CRPS, stimulating the specific DRGs related to the painful area might be more effective.
Any evidence for that?
Early results are promising. One key trial comparing DRG stimulation to traditional SCS for lower limb CRPS found significantly more patients in the DRG group achieved substantial pain relief and had better quality of life. Still needs more long-term data, but it looks encouraging.
Interesting. A more targeted approach. What about amputation? Is that ever an option?
Only in the most extreme circumstances, usually due to complications like uncontrollable infection or complete non-function of the limb, where quality of life is severely impacted by those factors. It should absolutely not be considered as a treatment for the pain itself.
Why not?
Because the pain mechanism is often centralized by then in the spinal cord and brain. Removing the limb doesn't remove the central pain generator, and there's a very high risk of persistent phantom limb pain or even recurrence of CRPS symptoms in the stump. It's truly a last resort for non-pain reasons.
That's a critical point.
Yeah.
Okay, one last area of prevention. Can anything be done to stop CRPS from starting after an injury? You mentioned vitamin C.
Yeah, there was hope for vitamin C, maybe due to antioxidant or anti-inflammatory effects. Some early studies, particularly after wrist fractures, suggested taking vitamin C might reduce the risk. But subsequent larger studies and meta-analyses have produced mixed results. Some show a benefit, others show no difference. The overall evidence quality is considered low.
So should people take it?
Despite the weak evidence, because it's generally safe and inexpensive, some guidelines still suggest considering it maybe 500 milligrams daily for 50 days or so after wrist, foot, or ankle surgery or fracture. But it's definitely not a guaranteed preventative.
Understood. So wrapping this complex topic up, it really sounds like there are still huge challenges in understanding and treating CRPS.
Absolutely. The evidence for many treatments is limited. The condition itself is so variable, what works for one person might not work for another, likely because the underlying mix of mechanisms differs. And we know even less specifically about CRPS type 2. Designing good trials is tough because of this variability. So clinicians often rely on that trial and error approach, combining therapies, focusing on symptom control and functional improvement. More research, especially on combination therapies and identifying patient subgroups, is desperately needed.
This has been incredibly informative, a really deep dive into a condition that deserves more understanding. What are the absolute key takeaways for our listeners?
I think the main things are, CRPS is a complex chronic pain condition, often triggered by injury, but involving disproportionate pain and changes linked to the nervous and immune systems. Diagnosis is clinical, using criteria like Budapest, and needs other causes ruled out. Treatment requires a multidisciplinary approach. Physical and psychological therapy are key, often alongside medications and possibly interventions like blocks or neurostimulation. And because it's so variable and unpredictable, early recognition and personalized care are really crucial.
A great summary of a very challenging condition. Thanks for breaking that all down. And it leaves us with a thought, doesn't it? Considering how intertwined the nervous and immune systems seem to be in CRPS, what if the future lies in developing treatments that can precisely modulate that crosstalk? Could we fine-tune the communication between nerves and immune cells to restore balance and offer more profound relief? Something definitely worth exploring. Thanks for joining us on the Deep Dive.